Dr. Rishi Swarup. Is Dr. Rishi here? Sorry, I'm sorry. I'm looking there, not here. So Dr. Rishi needs no introduction. He's going to be talking to us about the approach to dry eye disease. Meanwhile, I hope you are having a wonderful stay here in Uttarakhand. If there is anything that you can or we can make your stay better, you can please reach out to the local committee and we would try and make sure that things are better for you. Thank you.
At the outset, I'd like to congratulate the organizers of the midterm for a wonderful meeting and for giving me an opportunity to participate. Okay. Yeah, so my topic is approach to dry eye, and it's a very big topic, so I'll just try and quickly run through the key points, and we can always have questions later. So as we all know from the DUSE 2 definition of dry eye, it's a multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability, hyperosmolarity and ocular surface inflammation and damage and neurosensory abnormalities play etiological roles. This is the first prescription 3,500 years ago for dry eye. If a man's eyes are affected with dryness, he shall rub an onion, drink it in beer, apply oil onto his eyes. Thou shalt disembowel a yellow frog, mix its gall in curd and apply to the eyes. So this is the first official prescription for dry eye from the Assyro-Babylonian ophthalmology. So when you're talking about dry eye, it's a good idea to look before we leap. You know, the moment the word dry eye comes, we think about just giving lubricants and starting some empirical treatment. But it's important to understand what your patient has, whether it's really a dry eye or some other mimic of dry eye, and what type of dry eye. And before you look at the eye, also look at the other parts of the body. So many of these patients have got associated arthritis or any other problem which we know can be associated with dry eye. So look at the patient as a whole, ask their systemic history, look at their lids, look for lid margin disease. If the patient has a habit of, while the patient is sitting in your clinic, look at them, what they're doing. Are they constantly putting a handkerchief into the eye and fishing out mucus? You know, mucus fishing syndrome can present with all the symptoms of dry eye, but it's not strictly speaking a dry eye, although it can be caused by dry eye. And you'll have this typical conjunctival defect in the inferonasal quadrant caused by the trauma from fishing out mucus, and that can give you the symptoms similar to dry eye. Superior limbic keratoconjunctivitis is another condition often associated with thyroid, but even dry eyes can have it, in which you have redundant conjunctiva in the superior bulbar area, and that because of friction causes inflammation of that layer, and that's what gives you all the symptoms again, which can mimic a dry eye. But then if it's not from dry eye, it needs a different treatment altogether. Vernal keratoconjunctivitis is often mislabeled as dry eye, and dry eye is often mislabeled as allergic conjunctivitis. So look at the lids, see if there are lots of papillae, is there inflammation, is there lid margin keratinization or something else going on. So look for evidence of other diseases which can be associated with or mimic dry eye. Look for, this is again a very, very common entity which is highly underdiagnosed, conjunctivochalasis. You have these redundant conjunctiva in the lower bulbar area which bunches up like this. It prevents proper tear surfacing, and again because of friction there can be inflammation and symptoms similar to dry eye. So you need to address it by shrinking that conjunctiva or tightening it surgically. You have another entity called lid parallel conjunctival folds, lip cough, which is a useful non-invasive dry eye screening tool. These are basically, you see these kind of parallel folds near the lid margin in the conjunctiva, and these are have a positive correlation with subjective symptoms of dry eye and also severity of dry eye. So number of folds, more the number of folds you have, the more its significance. It's different from conjunctivochalasis, which is shown on the right. And this has been described as one of the signs of dry eye. And there is in fact a grading which has been described, and it's ideal to see this at a magnification of 25x without fluorescein on the bulbar conjunctiva just above the lid margin. This is called LASIK-induced neuroepitheliopathy or line. Often after LASIK, we'll see these patients coming with staining in the flap area, and that is basically because you have damaged the corneal nerves during either the making of the flap or the ablation, and it's basically a neuroepitheliopathy rather than truly a dry eye, but of course treatment is similar. So first rule out other conditions, then you have to try and see what type of dry eye it is and what is the severity, and for that I think a proper diagnostic methodology has been suggested by the DUCE-2, in which we do a stage algorithm, we do questionnaires, functional tests, then specific tests for tear film stability and abnormality of the tear film, and then tear volume, composition, etc., damage to surface are assessed. So this is the algorithm which has been proposed by the DUCE-2. Initially you ask the triaging questions to find out whether it's something other than dry eye, and then you do a risk factor analysis. If you suspect dry eye, look out for smoking and medications, contact lens wear, etc. Then we do screening using one of the questionnaires like the DEQ5 or OSDI, and then you go for homeostasis markers like tear film breakup time, osmolarity, and ocular surface staining. Then we want to do a subtype classification into evaporative and aqueous deficiency, although not all patients fit into a distinct subtypes, and many of them fall into a spectrum and will have a combination of the two, and this again further is graded. So dry eye diagnosis is basically from symptoms and a positive result for at least one of the homeostatic markers, which may be tear film breakup time, osmolarity, ocular surface staining. This indicates dry eye disease. Multiple tests improve the sensitivity. Symptoms in the absence of any clinical signs suggest a possible neuropathic element, and such cases should be managed to avoid the manifestation of dry eye disease. Sometimes it may also be a good idea to look for some psychopathic or any other pathology which may give those symptoms without signs. The sequence of testing should be from least invasive to most invasive, and rule out the other differential diagnosis like we mentioned in the initial few slides. So questionnaires, we have these two which are popularly used, the DEQ5 and OSDI. So DEQ5 score of 6 or OSDI score of 13 indicates a positive result. There are other questionnaires as well which have been kind of tested and have been found to be good. So what is the importance of using validated symptom questionnaires? We don't want to ask the patient unnecessary questions which will not elicit symptoms. So you want to ask them a standardized set of questions. You want to try and assess the severity of symptoms during screening and monitor progression of the condition and response to treatment. So you can even use them during follow-up. And symptoms should be measured similar to measuring signs, which you can now quantify here. And it enhances the standardization of the questioning. Next, coming to the diagnostic tests, which are also called the homeostatic markers. So tear film breakup time, I think, is the most valuable test that you can do. If you don't do any other test, this is one test which will very easily be able to differentiate your evaporative dry eye separately. So if your tear film breakup is low, you know you're looking at an evaporative kind of a scenario. And if the tear film breakup is actually low, even a Schirmer's being high may be very common in evaporative dry eye. So Schirmer's is more specific for, a low Schirmer's is more specific for a aqueous deficient dry eye, and a low tear film breakup time is more specific for a evaporative dry eye. So these two I think are certainly very useful. Anything less than 10 indicates some form of a dry eye. Again, in this we have invasive and non-invasive, etc. In which non-invasive you can use a grid like in a topographer. This is a fluorescein based tear film breakup time. So you want to look at the first random dry spot from the time that you have instilled the dye till the first dry spot appears random, not at the same spot. Second is the measuring of osmolarity. Now in the clinical setting it's not very easy to measure osmolarity. We have devices like the TR lab which have been available, but they are not perfect. Ideally you should take it in a micropipette and measure it in the lab, which is not possible in the clinic. So although it is a very good test for dry eye. Clinically, it's not really so easily measurable. So with the tear lab, they have found that the interocular difference of more than 8 milliosmoles is suggestive, and they have given cutoff values for the osmolarity per se. Is my time up? So I'll just quickly run through a few more slides. Can I take 3-4 minutes more? So ocular surface staining, we all know. Lissamine green is rose bengal are the vital dyes, but fluorescein is the one which we commonly use. So based on all these tests, you want to kind of try to classify into aqueous deficient and evaporative dry eye. Other tests like OCT can also be used to kind of get a meniscometry. Meniscus height itself can be measured on the slit lamp, and now we have devices which can do that. Schirmer's is again invaluable, and a cutoff of anything less than 5 is a diagnostic of aqueous deficient dry eye. Between 5 to 10 is a borderline, and you can kind of look at other things to kind of come to a diagnosis. Evaporative dry eye, you want to also look at the meibomian gland assessment, meibography. This is an image of a meibography. These are my lids, in fact. So you want to see how the glands are, the profile, whether there's thickening and tortuosity or complete dropout. That tells you whether the glands are blocked or they are completely dead. This is again my lippy view, which gives you an idea about the thickness of the tear, the lipid in the tear film, and also it can give you an analysis of your blinks, how many blinks you're doing, whether they are complete or incomplete blinks, because these also can contribute to your dry eye. Of course, evert and look at the lids as well. You want to look for lid viper epithelopathy here. You can see lissamine green staining in a patient with no symptoms and no obvious signs, but once you stain, you can see that line there. We talked about tear lab earlier. So that's about diagnostics. Therapy, I'll just tell you about the management strategies. So you want to either supplement tears, retain tears, you want to stimulate tears using secretagogues, substitute tears, anti-inflammatory theory, and environmental strategy. So the DUES 2 has told us a stepwise kind of approach for management and you go one after the other, and essentially these are the various modalities that are being used. So if step 1 doesn't work, you go to step 2 and then 3 and 4. So step 1 is essentially education, dietary modifications, removal of the offending systemic or topical medication, lubrication, and lid hygiene and warm compress. Step 2, if it doesn't work, then you go to non-preserved lubricants and look for specific treatments like Demodex treatment. Punctal occlusion can be done with plugs, etc., and other in-office heating devices, etc. So all your lippy flow, etc., will also come into this, and IPL. Steroids or anti-inflammatory agents, etc., will also come into this, and oral tetracyclines. Step 3 is when step 2 doesn't work, oral secretagogues, autologous serum drops, therapeutic contact lens, soft bandage contact lens, and rigid sterile lenses. Finally, step 4 is prolonged steroid therapy, surgical treatments like punctal occlusion, tarsorrhaphy, salivary gland transplantation, amniotic membrane transplants, etc., will come into this. So when we talk about lubricants, some of the things we want to look for in a lubricant is whether they are got what type of preservative they have. So when you're looking at the preservative, you have toxic preservatives like BAK, you have less toxic like polyquat purite and sodium perborate, and preservative free. Obviously preservative free is preferred whenever you need to dose more than 4 times. If it is less than that, then possibly any preserved lubricant can be used, and milder preservatives are definitely preferred. Several viscosity agents are available. All of them work well. Some have a slightly longer retention time in the eye, like sodium hyaluronate, but otherwise, I think more than the active agent, it's the additives and the preservatives that really matter in dry eye. So the goals are to increase the dwelling time, longer lasting protection, minimize blurring, minimize lid caking, improving comfort, and avoid irritation which may be caused by preservatives. So like I said, preservative free, hypoosmolar, and substitutes the roles of mucin and lipid, especially for cases of evaporative dry eye. Gels and ointments also have a role to play, especially in evaporative dry eye. So I won't go into all of this. We've kind of covered that. IPL is another option. Lipiflow, anti-inflammatory therapy, topical cyclosporin is the mainstay, but short courses of steroids also do have a role. I'll skip the surgical treatments and plugs. So to conclude, it's important to diagnose dry eye systemically after history questionnaire, clinical evaluation and diagnostic tests. Management strategies depend on the cause and type of dry eye. Medical management with tear supplementation and anti-inflammatory drugs is the mainstay of therapy in most cases of dry eye. More advanced cases require surgical measures to increase tear retention or tear production. Thank you.